for joining us for today's Ipsos virtual roundtable discussion about innovation, inclusion, and insights in achieving health equity. Today's roundtable guests are among the most talented experts in the industry. And throughout today's session, you will remain in listen-only mode. However, throughout the webinar, you may submit questions online using the Q&A feature. Time permitting, we'll try to answer your questions at the end of today's session. However, if time runs short, then your question will be answered by email. Today's webinar is also being recorded and will be directly emailed to you. So now, without further ado, it is my pleasure to introduce today's moderator, Janelle James, Senior Vice President with Ipsos UU. Janelle, you have the floor.
Thank you so much, Ellen, and thank you so much, everyone, for joining us today. We are thrilled to host this conversation with these amazing leaders who make great contributions to health equity today. There's no shortage of dismal statistics about healthcare and health access for many marginalized groups in the U.S. And like all diversity, equity, and inclusion efforts, health equity is challenging. There are lots of ups and downs, but these experts have helped their organization make progress. So we are excited to have the opportunity to learn from them. So with that, I would love to have our panelists introduce themselves by telling us their role, a little bit about their role, and a recent project or initiative that they've worked on that touches health equity. So with that, I would love to start with, actually before we continue, I want to say that one of our panelists is joining us only via audio. So we'll have to imagine what he looks like. You did have an image of Carlos or Mr. Nunez beforehand, but definitely want him to be part of the conversation because he's an amazing contributor to this topic. So with that, let's actually start with Carlos.
Yes.
Perfect, and thank you, Janelle. And as you said, my name is Carlos Nunez. I am a physician and the chief medical officer of a company called ResMed, one of the leading med tech and digital health companies in the world. We make ventilators and respiratory equipment and software in the healthcare space. And you can imagine, since we make ventilators, we were very, very busy during the beginning of the pandemic. And I have a very interesting role because I don't just lead medical affairs, but within ResMed, I also lead government affairs and market access. And so we have a really interesting organization that allows us not just to generate evidence, but then to use that evidence to have impacts, not just with our patients specifically around respiratory disease, but also about these topics of health equity and diversity and inclusion. And I would say that probably a recent exciting thing that's happened in my work is that just last week, someone on my team and I will be leading our company's ESG efforts. Focusing on the S, on the social, because as a medical device and med tech company, the social impact that we can have is probably our greatest superpower. So thank you.
Love that. Thank you. Alexis, do you want to go next?
Sure thing. And hi, everyone. So excited to be here with you today. My name is Alexis, and I'm a principal with Ipsos' Healthcare Advisory Team, specifically working in our patient-driven transformation group. And so I'd say most of my work focuses on how we can rethink our method for product development to make the healthcare system more effective, more efficient, and just overall kind of revamp the ways that we bring solutions to patients. And so one initiative that I'm really excited to talk about here today is our equity work. And so we just recently in January announced a partnership with Ipsos, the Health Foundation, and a number of coalition members, which fortunately Carlos and ResMed are part of that coalition with us. So really, really excited about that. We're passionate about redesigning the way that health tech is in particular brought to patients and making sure that equity is integrated in at the forefront of all organizations. So really excited about that work and to speak about it a bit further later on. Thanks, team.
Wonderful. Alexandria, you're up next.
Awesome. Thank you so much, Janelle, for having me. My name is Dr. Alexandria Wise. I am the Principal Medical Science Director at Genentech. My role is a bit challenging, a bit different. I'm transitioning out of our Alzheimer's therapeutic area space and moving into our what we call pan neuro. So essentially looking at different aspects of our portfolio that all specifically cover the neuro space. But my role is in essentially looking at closing the gaps on health disparities that exist and really helping to identify what could be potential solutions in order to promote either earlier diagnosis access or access to better health care. And so really understanding how we can improve that for all patients.
Love that. Charles, you're up next.
Excellent. Well, hello, everybody. Thank you so much for dialing in today. It's wonderful to meet you all, and such a thrill and a privilege to be on this panel with so many distinguished leaders. I'm Charles Fan. I lead global growth for a healthcare company called Babylon Health. In case you've never heard of us, Babylon is a company that's dedicated to putting a high quality, affordable, and accessible health service in the hands of every person on Earth. And I know it sounds wildly audacious and bold, but that actually is very much what we do. We work actually at this point in 15 countries on 4 continents. And they range from very modern countries like the United States or United Kingdom, all the way to other countries like Rwanda and Myanmar. But the point is that we're rapidly thinking through how do we improve population health by really harnessing the power of primary care and social determinants of health and really a prevention toolkit to help drive greater clinical outcomes across all sorts of different populations. A lot of our tools start virtual first, but then are seamlessly integrated with brick and mortar care. But what that means is it almost expressly puts our toolkit to bear on things like access deserts, healthcare inequalities, rural populations, anywhere we find very disparate, sub-optimized pockets of clinical outcomes. And so candidly, not a day goes by that we're not talking with clients about social determinants of health or rural health gaps and things like that, oftentimes that have various forms of disparity across populations. And so again, appreciate the opportunity to join you all.
Wonderful. And last but not least, Kim.
Hello, everyone. I too am really happy to be here and just feel like I'm getting so full of knowledge just from the fellow panelists. It's wonderful. So I'm a qualitative research consultant with Ipsos, so I'm a moderator. I'm very involved in our diversity council, and I specifically focus on many projects related to health equity. Probably one project or initiative, as Janelle asked, it comes to mind. I'm working with a large health system on understanding barriers to clinical trial participation amongst Blacks, Native Americans, Asian Americans, and Hispanic Americans. So it's a really rich project and really understanding what's going on behind the surface that's keeping individuals from participating in trials. I'm partnering with Ipsos Behavioral Science Center, so we're really getting deep into those layers of what are the barriers, what are the psychological drivers, and all that comes into play as people consider clinical trials.
Love that. Thank you. Now, everyone, I have kind of a creative or weird question for you, depending how you want to think about it. I would love for you to come up with a nickname for yourselves, but not any old nickname. I am looking for your health equity or diversity, equity, and inclusion nickname that helps me understand what your priorities are when you're doing this work. Now, I know that's weird, but I'm hoping you have a good name. So I am going to call on Alexis first. Do you have a name for us?
Sure thing. Yeah, I love this question. I think it's great. I think the best nickname for myself would probably be Sherlock or Sherlock Holmes, because I think one of the things that I'm really passionate about in our current equity work is all around asking better questions and then connecting the dots in maybe a new way that they haven't been connected before to uncover, a new solution or something of the like. So call me Sherlock.
Okay, Sherlock. Carlos, you're up next. Do you have a name for us?
I do. It's a variation of a nickname I was given by a reporter once. They called me Techno Doc. excuse me, and I shortened it to Tech Doc because every time I would say Technodoc, people think I'm a DJ. And even though it's one of my hobbies, I'm not very good at it. So you don't want me to spin techno music for you. You want me to figure out how to use technology to improve access to healthcare. So Tech Doc.
Okay, Tech Doc, thank you. Kim, you're up next.
I love that. I love that. I'm thinking about Black History Month now, what's left of it. And I think my nickname is Sojourner Truth. She was a
Okay.
powerful storyteller, and really amplified the voice of people who are struggling. So I really love truth in her name as well. So I feel like my role in health equity research in particular is to really bring forth the voice and the truths that many patients have as they're struggling to navigate a system, if they're not white, a system that really wasn't designed for them. So I'm all about the truth. So Sojourner Truth.
Love that. Thank you. And love the nod to Black History Month.
There we go.
Alexandria, you're up next.
Yeah, I have to go also similarly, I'll call myself the digital doc. Maybe a little slight variation there from our other panelists. So one of the initiatives that I'm really excited about working on is really how do we improve screening, particularly for neurological diseases. You have quite a difference and quite a challenge, right, of individuals getting that earlier screening. And sometimes you just have the worried well. So I'm really interested in pre-screening and screening activities that we can utilize, particularly as it is, make it mobile, make it easy, make it accessible, make it quick. To really help people kind of navigating their disease or their diagnosis, but also navigating the, just their healthcare journey. So yeah, the digital doc.
Okay, and last but not least, Charles, what's your nickname?
Wonderful. Well, I guess I'm going to continue some of the theme here. The name that a couple of folks had given me in the past was the Wandering Ponderer. And how they got that was my favorite book is Guns, Germs, and Steel by Jared Diamond. And if anyone hasn't read it before, it's effectively a book that reflects back to his high school years when he was asking why did Western Europe come to dominate the world? And the answer was they had guns, germs, and steel, and nobody else did. But the question really what remained unanswered was, well, why did Western Europe come up with those and nobody else? Right? And I feel like the healthcare conundrum is a very similar one here. As Kim described, I think we can trace, the immediate cause that there are areas of non-representation or a system that isn't necessarily designed for everybody. But why is that so? And I think that's a really interesting question that helps us peel back the layers on how do we solve it. And the wandering part is I'm a huge international traveler. I've been to about 67 countries now. And it strikes me as just fascinating how similar the problems are across the world and just how similar all people are. So thanks.
Love that. You guys did a great job with this. I guess my first real question or more serious question is, what drew you to a role in like healthcare and health equity, and what keeps you there? Alexandria, do you want to kick us off with that?
Sure. So my PhD looked at neurogenetics, so very far from health equity, but I have always been very, very strong, passionate, and advocate of really promoting, again, Blacks in STEM fields and really helping to develop more and more of our talent pool in particularly the in the neuroscience area. And so that has always been a cornerstone, a belief of mine, and really helping to, in this journey, realize this in many different ways. And so in my current position, seeing this through in, in clinical trials and access to clinical trials. And so I see this as not as it's not a job, right? It's an obligation to make sure that clinical trials, that patients have equitable access, that we are seeing the change in diversity within these clinical trials, and that patients really understand that this can really help us understand more about their disease progression, but also how to better supply them with the right tools, right, to navigate their disease. And that is a real imperative that I've taken up. And so that's why I've been so passionate about it.
I'm going to skip ahead a little bit. I want to talk a little bit about the social determinants of health, because that often comes up when we're talking about health equity. How do you think about them? How do you prioritize them? I've heard it outlined as, education, access and quality, healthcare access and quality, economic stability, neighborhoods or housing, and then social and community context. So are any of these more important than the others? Why? How are you thinking about this? Charles, do you want to take a stab at that?
Yeah, sure. This is a great question, Janelle, and one that I've often actually pondered, because it's almost like choosing between your children, right? When all of them are an important part of the
Yeah.
overall puzzle. When I think about social determinants of health, I actually think about them oftentimes as a series of almost like cascading bottlenecks. Right? And what I mean by that is, at the very starting point, right? If somebody is not educated on what does health actually look like, what are healthy habits and things like that, you can bring a horse to water, but you can't necessarily make them drink, right? And along with that, when you think about things like prevention and lifestyle being, upstream of healthcare, but very much, the entry point, if you will, into what is the healthcare system then going to need to treat. Second thing I'll throw out is that, I love the fact this is a health equity forum, not a healthcare equity forum, because I do feel like the holistic view of health is actually a critical lens that we're oftentimes missing so much in the healthcare space. I'd argue the traditional system that we think about today as healthcare, technically it's actually a sick care system, right? It actually takes care of you once you've already become ill or already have a condition. And how much more can we think about then the work that's needed upstream, the healthcare part on the prevention and stuff like that. But once you solve that first set of bottlenecks, only then do you start worrying about things like access, right? The availability of physicians, as well as removing the barriers like transportation and housing issues and stuff like that. And finally getting to some of the quality sorts of challenges. I guess at the end of the day, I feel like as you de-bottleneck a factory line or something like that, right, there's going to be a balance on each of these, because the more you free up the upstream, the more you're allowing the flow of patients and clinical needs to the downstream. I guess my only point is it's going to be an iterative sort of answer, right? We'll solve one piece and then create another bottleneck, then have to solve other pieces. But really, at the end of the day, people are holistic, beings. And so I think it's going to matter, or it's going to be different by geography and different circumstances, where and when one is more important or less important. But I wouldn't deprioritize any of them in the aggregate.
Yeah. Carlos, how do you think about the social determinants of health, particularly given your new role under the ESG umbrella? I'm curious a little bit more about how you think on this.
Yeah, thank you. And, Charles made a really good point. We don't have a healthcare system. We have a disease intervention system, and we over-index on things like hospitals. And I heard someone say just a couple months ago, and it's a quote that I'm going to rob and use over and over. Hospitals represent where people go where we failed to keep them healthy, where the system has failed to keep them healthy for whatever reason. And so I would say one of the most important social determinants of health, given that context, is the fact that, I'm speaking for the United States in particular, we have a system that does not incentivize health and wellness. It incentivizes, as Charles was pointing out, and it incentivizes it pretty powerfully with money, that we do stuff and we get paid, and we only get to do stuff when you show up sick or injured or needing acute types of care. And the other types of care that are more important, like health and wellness and prevention, are deprioritized because you don't make a lot of money. And unfortunately, just that the incentivization that's built into the system creates that first social barrier to health. Not everybody has access to health insurance or a health system that will put them into this weirdly incentivized system. And so to me, that's one of the most important. We've been talking about things like value-based care for 3 decades, but yet we still deliver most care in a fee-for-service model. And that model leaves a lot of people behind. But that's not to say that the other social determinants are not as important. Like Charles was saying, it is sort of a cascade of bottlenecks. And I would say once you leave the health system and you start looking at the communities in our country, it's everything from physical distance to a healthcare provider, the technological divide between what you are able to do. I mean, what I can do on my smartphone to access my health information, my doctor, my prescriptions, it's pretty good. It's not as good as, say, the other apps that we use for other parts of the consumer technology world, but it's getting better. Most people don't have that. They don't have that access. They don't have that education. And at the end of the day, most people don't really even fully understand how the actions that they take in their lives will reflect on their health. And so it's a lot about education, especially educating those who are in control of our healthcare system to finally make those changes that are going to prioritize health and wellness for everyone.
Mm-hmm. Alexandria, any thoughts on social determinants of health?
Yeah, I mean, this is a really, again, a wide casting your net. I mean, really just sort of bumping up against any one of them, right, can significantly contribute to major issues within, the prognosis of the individual, but also their just general access to, again, the best affordable care. And what we see then is reflective of the challenges that patients also experience when just trying to navigate the system themselves, right? Not having the right, questions to ask, not understanding really fully or getting their access to their healthcare records, right? To really explain what has happened in the past, and then when, what to say to a doctor, that they're just meeting, right? Sometimes I've heard, patients will just bring a bag of medications, right? And they're just sort of like, here, doctor, this is what, I know that I have. And that's, that again, just goes back to, again, that education, right? Really helping at a fundamental level, right? Helping individuals learn and really help them to navigate the care process much more effectively to, again, promote better health and wellness for them.
I'm curious, how does systemic racism manifest in healthcare in your experience? Kim, I'm curious what you've seen, particularly given your opportunity to connect with so many patients. What have you seen?
I've seen two areas. I see systemic racism show up like cultural bias and impacting the communication. I think that Alexandra is alluding to between that doctor and the patient, where patients express not being heard, not being understood. And maybe to Alexandra's point, they're not presenting it the right way or asking the right questions, but there's some kind of, there's something going on, some bias with the provider who's interacting with some of the patients that I've interviewed. It also shows up when socioeconomic status and race sometimes intersect. So if you have a lower quality health insurance, it can, in the patient's mind, and does lead to lower quality care, pushed off to the side. You've got the state funded insurance. Maybe I'm not doing all that I can, subliminally or not, but there's something going on there between the patient's insurance, the patient's economic setup, and how they are received and perceived by the doctor. And that's what they're kind of feeding back to me.
We talked about incentives a little bit earlier, and I'm curious, when we think about this being a sick care versus healthcare system, is there anything with regards to systemic challenges or systemic racism that we should be aware of or we should be thinking about? Alexandria, Carlos, any thoughts?
Yeah, so I think I'm going to go back to the system of care within Alzheimer's disease. So African Americans are twice as more likely to be diagnosed, and Hispanic Americans are 1.5 times more likely to be diagnosed with Alzheimer's disease. However, this presents in many different ways, and if it's not caught early enough in terms of intervention, typically the typical prognosis is that African Americans and Hispanic Americans are diagnosed very late. They're unable to, participate in any clinical trials, because often the clinical trials we know for Alzheimer's disease occur much earlier on in sort of the MCI prodromal phase of the disease. But they're also less likely to be able to, make discernible executive decisions about their estate and planning, how they'd like to sort of, live the rest of their lives until it's much later on. And so I think there's a real need here, right, to, again, that promoting that awareness, but also, having the care facilities, right, really recognize what does the disease look like, in Hispanic patients, right, patients that maybe English is not the first primary language for them, right, and so their fluency may look a lot different in, in English when they're doing a test, right, an assessment, a clinical assessment. To determine their level of understanding, right? It may look very different, and so they may score very differently versus someone who is an English speaker who has had, from a high socioeconomic background and who is, cisgendered, white male, basically, if you want to call it. And so I think those are kind of the ways in which we can really spotlight and really start to understand and dig in a little bit more on how can we improve these systems to, again, as Charles had said, sort of let that bottleneck, improve the bottleneck and make it more of a flow.
Thank you. Alexis, I'm curious, what trend, technology advancement, or phenomenon has been most influential or disruptive when you think about health equity today?
Yeah, great question. I think the way I think about it, just thinking of some of the things that have been said so far in this conversation, we talked earlier about social determinants of health. I think the thing that keeps emerging for me when I think about it is, for a long time as an industry, we've acknowledged things like education are important, our workplace, our lived environment. That digital kind of tech lens, I think it's the importance of it is really only increasing over time, particularly, this post-COVID world. Tech is now the thing that can help someone transcend, that area where they live to get a different job opportunity, to be connected to different education, to be connected to healthcare. And so overall, when we were talking about social determinants of health earlier, I think more and more I tend to think of tech as a super determinant of health now. And I think it sort of related to this, we talked about, what's impactful, what's transformative. Tech is only as good as the specs we put in. And I think there's a lot of hope and there's a lot of good intent that's placed on health tech to make the healthcare system more effective, efficient, to provide better solutions at scale and to more folks and to increase health outcomes overall. But unless we look at who's designing the tech, what sort of specs they're putting in, what questions they're asking, what even foundational data they were looking at in the first place to kind of come up with those questions, it kind of also makes me think about that systemic racism question that you asked earlier, which is a great one, which we can't expect that the tech that we're putting out as an industry is going to solve these solutions when we're not kind of addressing some of the pieces there. So transformative, I think there's a number of really great partnerships and initiatives that have come out, and Carlos, actually, I know he's mentioned one as part of our Tequity initiative, so maybe he can give that specific example. But in terms of transformation, I think the big thing that comes to mind for me is health tech, that positive intent is there, but when we're not really being ultra mindful, ultra conscious of those questions around equity, I think we all have to, as an industry, acknowledge the fact that health tech more often than not can actually cause harm, not just not help, but actually, cause harm. And there's, multiple instances of that. I know last time we talked about our artificial intelligence and algorithms with, Black Americans and kidney transplants and a lot of the data that's been shown there. So without taking much more time, I'm curious if Carlos or anyone else has any, specific examples from their work that they want to share, because I know I've heard some great ones through our Tequity Coalition.
Yeah, it's Carlos. I'll jump in. When I think about technology, this is going to sound a little silly, but the most technologically advanced device that we've ever stumbled on in the universe is the human brain. And when you think about the way that we talk about bias and and things in AI, all the things with ChatGPT. There was an interesting New York Times article about how ChatGPT could go down a rabbit hole if you ask the wrong questions because of the training and the bias. It all starts with us. And I think it starts with the training that we give to clinicians to make sure that systemic bias doesn't taint the way that they view the job that they're supposed to perform. This can be a weird example, but bear with me for a second. I'm an intensivist, a critical care ICU doctor, intensive care doctor. And one of the areas that I loved the most in my training was learning how to help families deal with end of life. Had nothing to do with technology, ventilators in the ICU and monitors beeping in the corner. It was about connecting with a family, connecting with human beings, and using my training to be human and not just be, a human with a bunch of algorithms in my brain about how to treat or diagnose or help a patient through a disease or an injury. We need to think about that as we design tech, whether it's a large language model like GPT-3 or the apps that we put on phones that we expect people to connect with. Rooting out bias in education, rooting out bias in technology, and using our knowledge of how bias works to ensure that we do consider everyone when we make decisions about health, whether it's on a macro scale at a health system or country level, or that one-to-one interaction. So it's a weird way of answering the tech question, but our brains are still pretty amazing pieces of tech, and we need to make sure that we fill our brains with good information about everybody that we may come across as we treat or diagnose or just help someone. And that'll be a big part of it. And then it helps you design better tech so that the next person who designs the next large language model says, you know what, we're going to use a training database that's a little bit different to maybe get past some of the biases we discovered in previous iterations.
One of the things that we typically say with any sort of inclusive design is just making sure that the team and the data is cross-cultural. I'm sorry, I cut you off, Alexandra, you were going to say?
No, I think that was Charles, but I did want to make a plug there for the IAT, because I think this implicit assessment test can really help start that conversation about our own personal bias, whether or not it's low or high. I think this kind of training and helping folks understand that we all, if we are human, we have a bias of some sort, and it's going to happen. And whether or not you are actively, sort of inhibiting that sort of bias when you're meeting a patient, seeing a project through, selecting, vendors or external organizations to work with. If you're not specifically inhibiting that as we are interacting, then those biases will ultimately carry themselves through, right? This patient's not that adherent. This vendor didn't quite deliver on what my demands were. And so I think, again, that training comes for all of us, that we need to do the hard work of understanding where those biases originate from, but also actively promote how to inhibit that.
Charles, did you want to add?
Yeah, I couldn't agree more with all the answers thus far. I think, the key tenet here, I think, is that we're at an incredibly exciting inflection point within healthcare, and that technology, tools, and solutions are coming into the space at almost an unprecedented pace, especially when you look at the amount of capital that's going into health tech. But as many have correctly called out, technology, automation, it's a double-edged sword, because effectively what it's doing is it's replicating and scaling the system. If we're not very thoughtful and mindful about what we do, right, we can replicate and scale some of the elements that we don't want. I'll throw out the optimist side of it, though, as well, right, that these technology tools enable so many different degrees of freedom that previously were constrained by manpower, processing power, and things like that. So I'll throw out, Alexis earlier had described the drug development process and clinical trials and trying to take bias out. I'd also say, like, in the past, right, things like pharmacogenomics and precision medicine simply weren't doable. The Human Genome Project took 13 years to sequence the human genome. Today, we actually could very definitely look at different phenotypes and consider, all sorts of different things within our drug trials to get that data set to be more diverse. Similarly, I think a lot of people have described, the education gap, the engagement gap. I'd argue so much of that is bottlenecked by cultural constraints and cultural competencies, which again, if we have now orders of magnitude greater bandwidth and scale, right, it allows for us to design these various sorts of tools and solutions. And finally, when we talk about now the advent of virtual care, I think the world has become such a smaller place. Once upon a time, healthcare was exclusively practiced locally. Today, we can actually think about matching, patients with people that maybe look like them, come from similar backgrounds, have a lot of the same sorts of cultural competencies, and reflect then various models of care, engagement, and navigation across, much larger pools of supply and demand. And so again, I think it's fundamentally exciting right now. We can, solve all sorts of gaps on the identification, engagement, and intervention side, but we just have to be very thoughtful, inclusive in how we design all these pieces.
Yeah, no, I love that. I particularly what you mentioned around sort of cultural constraints. I have what I'm calling a little bit of a case study, but really stimulus, a story that I'm going to use as stimulus for the conversation. And unfortunately, I've had 6 friends pass away in about the last year, all between the ages of 40 and 50. Actually, someone just passed away last week, and she was not even 40, all in the prime of their lives, all amazingly educated, economically comfortable, and all of them, in amazing jobs, and making like an active impact to improve their own communities. None of them sort of the stereotypical image of, the Black person in America. And when we think about social determinants of health, I don't really see a situation where they were impacted in that way. But then I think about people like Serena Williams, who, in her maternal healthcare experience, experienced a lot of bias. How do we think about examples like this, where you have people with the education, the access, great health insurance, all these things, and they're still receiving care that they shouldn't? Anyone want to tackle that first? I know it's weighty.
I guess I can just share, Janelle, I interviewed a really a mid-level manager at an insurance company for one of my projects, the most recent one. I think the topic was around navigating the healthcare system. And she was expressing to me, I think she had postpartum cardiomyopathy, that is now, the baby's 4, progressed to congestive heart failure. And she was expressing to me that all through her pregnancy, people were watching her hypertension. Oh, it'll be fine. Oh, it'll be fine. She was speaking up, at least she thought she was. And doctors were saying, no alarm, no need for alarm. But lo and behold, there is a need for alarm. And so she's thinking, wow, who wasn't listening? I felt like I was saying something. It just wasn't working. And here she is, she's managing, congestive heart failure. So I keep wondering would her experience have been different if she had access to a doctor that looked like her, maybe connected with her better in whatever way, virtually, whatever, as you're saying, Charles, is that the difference? Choosing a physician that knows that your patient population. And then for her, I wonder if better tools and techniques to self-advocate, because the patients I interview have to do a whole lot of self-advocating, more than the white ones. I mean, a whole lot of self-advocating. So did she need a tool? What could we have armed her with to better self-advocate? Would it have been when to seek a second opinion? Would it have been a brochure on speaking with your doctor? Would it have been a YouTube video? Would it have been a quick webinar? I don't know, but it feels like there's an opportunity for healthcare systems, for pharmaceutical companies, and others to arm individuals like her with what is needed to self-advocate in these critical times with their health. So that's really what that brought to mind for me. How do we help with self-advocating?
It's interesting that you say that, because it's only when you said it that I remembered something that I did when I found out I was pregnant, and I was 39 at the time. I had just read an article in Essence magazine about maternal mortality rates in the Black community, and it being 8 to 9 times higher in New York City. And I'm like, I'm in New York. So like that was something I just kept in the back of my mind with every one of my prenatal appointments, to the point where like it forced me to just be very aware, ask a lot of questions, and sort of keep them more accountable. So it's interesting that you say that. Any other thoughts on this, Alexandria?
Yeah, so I was actually going to just mention my experience as well. Actually, having 2 daughters and having a C-section, and actually being on the table and having the nurse really yell at the anesthesiologists who could not perform a lumbar puncture. I was poked about 15 times before somebody finally got it. Passed out, came back. So that experience just even taught me just that even when I was saying this is painful, right? There's something that they're not even hearing. And only when the nurse, who is African American woman, who is listening to me and said, no, she is in real pain, yelled at the anesthesiologist, she is in pain, you need to stop. Did they in fact stop and, either try it again another 15 more times? So, I say all of that to say is those experiences, really help to kind of underscore again that bottom line, that basic need that you have to do more, right? We have to do more for our own health, and we have to be the ones that are going to be the proactive, I want to know about this disease because it seems like it runs in my family, and become educated. This, or I need to talk to my doctor about, have your laundry list and say, no, I'm not going to leave until I find out, these 3 things or 5 things, what have you. Those are the kinds of things, again, those tools that really help you navigate the care. I think of a digital app, right, that allows you to view your EMR records, right, really give you the access to your healthcare records and really be able to view that. Those are the things that I think of when we're talking about really promoting equity, right? It's not about equal services, but it's about the equitable service, right? How much more do I need to advocate for myself to allow me to get the access that I deserve?
So I'm hearing that there is a role for the patient, for the person, to be a more vocal advocate for themselves in this current situation. Any other thoughts or solutions when we think about this, Charles?
Yeah, I would throw out, I completely and wholeheartedly agree with the patient self-advocacy side, and I'm so sorry about the horrific experiences that have been described. But I do believe that there is a role on the system side as well. I mean, one thing I'll take a step back and say that I do think we are blessed with in healthcare is that at the end of the day, at its very distilled core, healthcare is fundamentally about altruism, right? It's about helping people. And that's not to say that there aren't some bad apples here and things like that, but I do think by and large, the challenge that we're usually facing is more like subconscious bias and like non-inclusive system design, which is an easier problem to solve, right, than actual like malintent or something like that. My former employer was a larger entity than Babylon, did actually invest pretty heavily in unconscious bias training and things like that. And I know that we're working on that ourselves as well. But at the end of the day, I do find that actually does, it almost unmasks some of the challenges that people might not know they ever had, right? And start thinking more broadly and expansively about other cultures, other heritages, other interpretations of the same sorts of events. At the end of the day, again, a beautiful thing about healthcare, it's one of the few spaces that there truly are win-win-win types incentives, right? When the system can keep people healthier, obviate the need for care, that increases supply and access, it actually increases or decreases cost, makes it affordable for everyone. Everyone's incentives are technically aligned here. And so it's a matter of actually, again, peeling back layers of the onion on where and how do we get to those outcomes that we're all looking for. But I couldn't agree more that there's a patient component in the short term as well as I think a health system component as well.
Relatedly, it's challenging to do research with go for it.
Yeah, I just wanted to jump in and mention 2 quick things. We several of you mentioned, nurses or other providers who've helped. We need to make sure that it's not just that patients know how to navigate the system and can advocate for themselves, which is extremely important, something that we need to focus on. But there are other providers in the system who often step up of their own volition as heroes. And I wasn't smart enough to go to nursing school, but I was smart enough to marry one. And, they are sort of the unsung heroes. And so hearing the story about, the Black nurse who saw that the patient was suffering and yelling at the anesthesiologist resonates with me because, as we over-index on physicians. And as physicians, it's sort of like a weird, demented vaudeville show. We come in and out for a few minutes at a time, do our little song and dance, and then we're gone. But it's the nurse or the physical therapist or the occupational therapist or the respiratory therapist or somebody else who's there with that patient all the time. And so we also need to make sure that everybody feels empowered to advocate for themselves, for their patients, for what's right. And so, I appreciate this discussion because at the end of the day, we will solve these problems not through technology, but through that human aspect of healthcare that makes it so different than any other industry.
I'm curious, it's challenging to do research with underrepresented groups. What are some of the most unique and effective methods you found for gathering insights to just get data that you need for these types of decisions when you think about health equity? Alexandria?
Yeah, so we have worked in a number of different ways, really assessing what is necessary for clinical trials, particularly in Alzheimer's disease. And one group that we've actually worked with was actually working with a community research advocacy group at the SUNY. So the State University of New York. Basically, they have a research accelerator group that is a group of 28 healthcare consumers. And we were able to speak with them and have them help us design clinical trials from the very beginning of the protocol design, but also helping them guide us, give us feedback on the various aspects of informed consent, as well as with, just outreach and engagement. What should we do? How should we do it? What digital tools can we employ that might help, again, to better illustrate what a clinical trial is and what participation would be like in our clinical trial. And so I think, I think of that example as going to, I would say, not necessarily your typical sources, right? So going to the sources that, really would, are either directly impacted or individuals that would directly benefit from the actual, either design or, I think tool or application that you're building, right? And really get their feedback in it. And it's the importance of embedding that within the way you're going about the day-to-day, right? It's not like, okay, here's a one-off and now it's all designed and now let's go and talk to someone who actually would benefit from, no, right? You got to ask before, you got to go earlier on, right? As you're developing things, really get that, that co-creative support, advice, from those individuals to really understand, is this going to be helpful? Is this going to, something that actually is more harmful than helpful? I also think of the example of the faucets, right? In if you go to a faucet, if you're more melanated, right? Sometimes the faucets work, right? If it's standing for, right, or they don't. Right, we know that this is.
Sometimes you get the soap, sometimes you get the water. You got to move things.
Exactly right. Right. Had we really had the conversation, right, with those engineers, not knocking the engineers. I love the fact that I'm not spreading germs by turning on a faucet, but I think it goes back to the simple design and engineering of, does this recognize all skin types, all skin colors? So again, from the inception of the idea, right, and really even making sure that the people are in the room, right, that also have that lived experience as well.
I had heard that oximeters, the little devices that those skin color impacts those readings as well. So it's definitely interesting about how some of these can be centered on. Yeah, go for it, Carlos.
Yeah, I was just going to say on that research question, we conduct a lot of clinical research. And some of it is for getting products into market, to get them approved by regulatory agencies. And we make masks for non-invasive ventilation and for things like CPAP machines. And we make millions of them, tens of millions a year. And our facility where we manufacture most of those masks is just outside of Sydney, Australia. And we have a testing program where we do research when we design a new mask to make sure that they fit and they're comfortable. And we call in people from the community. And if your head and your face are shaped like the average person in Bella Vista, New South Wales, just outside of Sydney, Australia, then, you know, boy, do we have a mask for you. But we realized that we were over-indexing design on people's faces that are really particular to one part of the world and not faces and heads and shapes and sizes that are more diverse. And so what we did was we just said, this is the metric. At least 40% of the people in our mask studies have to come from diverse backgrounds. And we can't do these studies only in New South Wales, Australia. Nothing against the folks in New South Wales. It's lovely. I'm actually here right now. But it allowed us to put a line in the sand and say, we're going to make our trials more diverse because that's what we're indexing on. That's the number that we've chosen. And until we hit that metric, we're not going to stop. And so I think a part of it is just being very deliberate and knowing there is a problem in medical research and clinical research, and you have to actively recruit and actively design studies to make sure you include a diverse population.
But
one of the things,
diverse patients are asked, right, to participate. Oh, I'm so sorry.
Go for it. Go for it.
Diverse patients, the patients I interview are saying, no one's asked me, the Black women, no one's asked me to participate. So there's a problem in how we're getting them, or maybe companies need help in how to reach them, how to recruit them. So the women I spoke with, a lot of them breast cancer, what they shared with me was that companies need to be more creative in connecting with their organizations, their social and support groups. So there's one called For the Breast of Us, who helps women of color with breast cancer and looking at skin tones when you get your mastectomy and, you know, all the things that go into breast cancer. But I wonder if there's a connection that could be made between diverse support groups, networks, community, grassroots, to inform them, inspire them, connect with them to be a part of the clinical trials, and maybe help a lot get over the mistrust of a clinical trial. You know what, the fear. So there's something there. I don't know what it is, but got to figure out how to get them in, because often they're not invited.
Yeah, no, that's very true. It is a very interesting and dynamic challenge, because on one hand, it's making the decision about the levels of diversity that are required, and then doing the work to source the diversity that's required. And we need it on both ends. And what I like about that is, you know, oftentimes health equity work, DEI work, it's not only for the marketplace, but also for the workplace. There's certain things that have to happen in our workplaces to fuel the type of innovation that we want to see in that regard in the marketplace. And so I'm curious, for you guys who are doing this work, tell me a little bit about some of the workplace work that you have to do to ensure that you're getting what you need from the marketplace, if that makes sense. Alexandria, do you want to start a little bit there?
Yeah, absolutely, because I think about this a lot. You know, I mean, within Genentech, you know, we've really, you know, I think we've pulled ahead in terms of really embedding, again, our diversity, equity, and inclusion by fostering belonging, you know, advancing inclusive research, and transforming society. And we have initiatives that cover all of those different those endeavors. But when you talk about workplace work, you know, I think it really talks to our fostering belonging, right? Really making sure that our workforce is really equitable, right? It really has diversity of thought, diversity of backgrounds present at the table, that allows for, again, this to be embedded, these kinds of ideas to be embedded, but also that there is just a different way of thinking. So we've gotten to our goal of at least more than half women in our company. We have a ways to go. We have decided to report our annual numbers of diversity of our directors and managers in our annual diversity report, and you can see that on our website. And then we've also have a 2025 goal where we plan to double the number of African American and Hispanic Americans in director level roles. And so I think that is, you know, again, those are the kinds of policies that help make it, you know, again, I'm not running to every single meeting because I'm the only one. Let's just say that, right? That more of us are there to share the voice and be advocates. And also that we are encouraging the allyship, right? The recognition of the challenges within our own communities, and allowing to bring that through, and that people can advocate on behalf of other people as well. I think that creates a workforce and a workplace that's, again, more inclusive and feeling more that you really are changing something, really are a part of something, and not just sort of the nice to have.
I love that. Charles, did you have some thoughts?
Yeah, a couple of, I mean, Alexis, great comments there in terms of what the company itself can be doing internally on the decision-making side. I'd love to link that with some of the comments in the prior answers of, again, about the intentionality that's required to bring in the right perspectives and data. I've got a couple examples from the work that we're doing at Babylon. The first one was really to just acknowledge that we don't know. Right? Like the assumptions, I think, are what kills us. It's almost the Mark Twain quote. It's not what you don't know that kills you. It's what you know that just ain't so. And so to some degree, right, like nobody goes to Rwanda to make a fortune. The average person there incurs about $40 a year of healthcare costs. The decision to enter the Rwanda market was truly to understand additional phenotypes and additional you know, basically genetics and genomics and cultural sensitivities, you know, very actively, proactively trying to seek those sorts of perspectives, data sets, stuff like that, I think is critical to making sure that things like AI algorithms are being modeled correctly. But also when it comes to, you know, again, if we think about probably the vast majority of folks on this call, we're the blessed of the earth, right? We are you know, upper middle class or better, folks mostly living in the United States. I mean, it's difficult for us to step out sometimes of just everything we know, right, and project into other socioeconomic classes, other cultures. We've very proactively made an effort to hire what we call community health workers. But the boots on the ground sorts of engagement work that we do, oftentimes it's almost unknowable to people, you know, in the corporate offices and things like that. We very purposefully are looking for people that are from these communities, from similar socioeconomic pathways, that can help us then understand, right, is the pathway to engagement through the local community organization? Is it the local church? Is it knocking on doors? What is the right cultural context? And also, when we were doing work with substance use disorders and stuff like that, well, sometimes what are the various cheats, right? The things that you'd never potentially think of, but there's a cleverness. Life almost finds a way oftentimes. And finding people that have lived and walked in those shoes is so critically important for making sure that everything we do actually fits.
Definitely. We have time for one more question. And the thing that I've been thinking about, I always like to wrap up with some sort of like tip or advice. But, you know, we've talked about a few different aspects of health equity. We've talked about health and wellness, preventative care. In your opinion, why should all brands, meaning across sectors, care about health equity? You know, why is this conversation important across categories? Obviously, we touched on technology as well and how that can power this, but I'd love to hear what you think that all sectors have to benefit from this conversation and what health equity can do for society. Alexis, did you want to dig in there first?
Sure, yeah, appreciate it. And just want to say how much I've enjoyed this conversation. So I think one thing I want to leave everyone with regarding this conversation, I think something that comes to mind for me is health equity thrives sort of in the shadows, and this opportunity that we have through tech to kind of shine a light is really, really valuable. And I really agree with the two comments that Alexandria and Charles just mentioned. And one thing I want to leave everyone with is health equity has to start internally in an organization. We have to be able to measure it, or else we can't move forward. And
yeah, go for it.
I'm happy to jump in very quickly. Yeah, I think, you know, to echo some of the previous comments, when we have the entire population of a state, a county, a country, the world healthier, more able to live their lives, do their job, connect with their families and friends and communities, every industry benefits. And the connections between so many things we do in life and our health and wellness are not always that apparent. I mean, I'm thinking of a study that was just published a few weeks ago that showed the higher rate of adoption of electric vehicles in California has led to a decrease in emergency room visits for asthma attacks in the areas where EVs are most deployed. And so you never know where the connections are going to be.
Yes.
So whatever we can do, whether it's technology, whether it's that human touch or a little bit of everything, to make sure that people are happy and healthy and can live their best lives where they want to live those best lives, that's how healthcare makes a real difference. Yes, it's important to cure diseases and help those who are sick and injured, but man, we want to go from that disease intervention system to a healthcare system that includes everyone and leaves behind no one.
Oh, thank you. Oh, go for it, Charles.
Oh, I mean, just 2-second one here. I certainly appreciate everybody both participating as well as dialing into this forum. One of the things that always struck me is we think about this DEI work as being progressive. It's something that's on the leading edge of healthcare. But I'm always struck by the fact that today about 39% of the American population is classified as people of color. It's going to be well over 50%, right, in the very near future here. And so this should not be something that we're thinking about as a nice to have or something that only leading progressive thinking organizations, right, are thinking about. This absolutely needs to be core and fundamental to everything we do as just a sheer part of the healthcare system.
No, thank you. I honestly would love to go for another hour. We're a little bit over, so I must thank you for all of your contributions. You guys were absolutely amazing. And I may actually reach out to you for us to have a part 2, but I do have to say goodbye for now. And thank you so much for your contributions and your brilliance. Ellen, back to you.
Wow, I just really want to thank everyone for taking part in today's truly dynamic conversation. Be on the lookout, everyone who's joined us today, for a link to today's recorded presentation. We expect that should be available in the next day or two. And in the meantime, please reach out to us directly with any questions. Have a wonderful day, everyone.
Thanks all.
Thank you.
Thank you.